Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, and I'm your host for tonight's program on arthritis. We will be glad to take your calls on arthritis, bursitis, tendonitis, and rheumatism. The success of this program is very dependent upon you, the viewer. Please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists for this evening's program include Dr. Gail Baldwin, a family physician at the Veterans Administration Twin Ports Clinic in Superior. Dr. Wasim Khan, a rheumatologist with St. Luke's Rheumatology Associates in Duluth, and Dr. Christensen, a family physician with the Gateway Family Health Clinic in Moose Lake. Our medical students answering phones tonight are Anna Gregoire from Marshall, Minnesota, Bobby Johnson of Wilmer, Minnesota, and Austin Spronk of Edgerton, Minnesota. And now on to tonight's program on arthritis. Dr. Baldwin, we've got several topics tonight. Do you want to tell us a little bit about, let's talk a little bit about bursitis.
Well, bursitis is inflammation of a bursa, and a bursa is, I call it the little fluid sac that rides in the area of the joint over which the tendons ride to make the joint move more smoothly. So when it's inflamed, things get sore and things don't move so smoothly. So commonly, places that get bursitis are like the shoulders and the knees can have problems in those areas. And that's bursitis.
Thank you. Dr. Thiessen, do you want to talk a little bit about tendonitis?
Sure. Tendons attach muscles to bones and can be strained just like the muscles themselves. You can also get tendonitis from a repetitive strain when you do something over and over and get carpal tunnel, for example. You can also get tendonitis as a part of another type of arthritis, such as an inflammatory arthritis or rheumatoid arthritis.
Dr. Khan, I've kind of left the arthritis group to you, and do you want to open up the discussion on arthritis for us?
Sure, it's a vast topic, but the key to realize is that arthritis is basically a derangement of a joint. Now, a joint is a place where two bones articulate to facilitate motion. So the knee joint is basically an articulation between the shin bone and the thigh bone. And if it weren't for that, if it were just one bone, we won't be able to move. So the whole idea behind the joint is to facilitate movement. Now, whenever there is a derangement of a joint, you call it arthritis. Now, broadly speaking, there are two types of arthritis: mechanical or degenerative arthritis, where there is wear and tear, or inflammatory arthritis, where the immune system is overactive, or in gout, where inflammatory cells invade a joint and cause a lot of swelling and redness, and you treat them completely differently. So,
Gail, could you talk a little bit about osteoarthritis or degenerative arthritis?
Well, degenerative arthritis, we really don't know specifically the cause, because some people can work their whole lives doing very hard labor and never develop any arthritis or wear and tear of their joints. And other folks who have not necessarily done heavy work will develop wear and tear where the cartilage, or I call it the bumper pad sort of the bones where they meet. The cartilage will degrade and then the bones start to rub against each other and they wear. And that will be painful. So you'll get a change in not only sometimes the pattern of the way the bones are, if they're supposed to meet directly like this, and then they wear and suddenly they're meeting like this. You have a change in the pattern of wear, so that can affect the joints downstream and upstream too, because then the pattern of wear is different there as well. So it's a painful process, not necessarily with inflammation, and we don't know exactly why it occurs.
So the discussion, I'm an old marathoner and did it with way too much weight. The discussion and the concern was those of us that did a lot of marathoning and a lot of running were going to have more osteoarthritis. Is that true?
In fact, that's not exactly what ends up happening. People who stay active actually seem to do better.
And I think part of that may be the distinction between the actual wear and tear versus the amount of pain and dysfunction you have from it. Because I've seen that people who do some sort of activity still tend to be able to use the joint and may have less pain, even though you see more wear and tear.
So is running in the swimming pool a good thing for people with arthritis?
I think it's great.
Yes.
Dr. Khan, you were going to say something. I'm sorry.
Because a joint is not just the two bones sort of in contact with each other, but also it's a structure which is surrounded by muscles, tendons, and when you're more active, let's say if you are a marathoner, as in your case, the muscles and tendons are supposed to be in a much better shape. So on an X-ray, two people may have the same amount of arthritis, but one person who is fitter and has sort of stronger muscles and tendons may have less pain even with the same degree of arthritis compared to another person who may be in not that good a shape. So
does heredity play a part in osteoarthritis, degenerative arthritis?
Clearly.
How about rheumatoid arthritis?
Yes, rheumatoid arthritis is a completely different type of arthritis, although both are arthritis, but they are like chalk and cheese. Rheumatoid is inflammation, and the problem there is an overactive immune system. Now, unlike osteoarthritis, which typically sort of grows on you as you grow older, rheumatoid arthritis does not respect age. So you can get rheumatoid at age 3, or I've seen ladies getting rheumatoid in their early 90s. They're treated very differently. In osteoarthritis, you mainly focus on relieving symptoms with anti-inflammatories, Tylenol, physical therapy, local injections, surgery. But in rheumatoid arthritis, the medications are mainly geared towards controlling sort of an overactive immune system. So the drugs basically work on tamping down the immune system so that there is the joint damage doesn't keep progressing. Because if you leave rheumatoid untreated, the joints, you can have significant joint damage within 2-3 years. Before some of our current medications for treating rheumatoid arthritis 30 years ago, half the population with rheumatoid used to end up crippled or in wheelchairs within 5 to 7 years. We don't see that anymore. So the key is to diagnose it early.
Is there a new treatment for rheumatoid arthritis? That's a question that was called in.
Yes. Oh, the treatment of rheumatoid arthritis, I think it has improved dramatically over the past 20 years. I mean, 20 years ago, most of our treatments were drugs like Plaquenil, sulfasalazine, methotrexate. Now, those are still effective drugs, and we still use them. But in a sizable proportion of patients with rheumatoid arthritis, those are not just enough. So we have these biologic drugs which have been tremendously effective. And I mean, we are at a point where we are seeing patients with rheumatoid arthritis who 30 years ago would be in a wheelchair, and now they are running grandma's marathons. So literally, I mean, I have patients like that.
So should a rheumatoid arthritis patient get a DEXA scan every year?
Not every year, but if they are on prednisone, they should get it at baseline. And depending on if they continue to be on steroids down the road, maybe it should be repeated yearly. But it all depends on how bad their bone density scan is at baseline. So you have to individualize it.
Chris, you want to jump in?
I think most medications for rheumatoid arthritis don't affect the bone density. The steroids do, like prednisone.
Yes.
And similarly with osteoarthritis, I think most medications for that don't affect bone density.
Gail, there's a question. I'm going to flip back to degenerative joint disease or osteoarthritis again, which are the same thing in my mind.
Yeah.
So as
Mine
long
too.
as, okay, so we're all in agreement. Is there a limit on cortisone shots?
A limit? That's also a very individual thing. I would say that for an individual, if I was using that as opposed to other therapy, I'd like to see at 6 months of improvement with a shot, and I would like to not do more than 3 in a year. Now, the exceptions being if you've got someone who has really no other alternatives and gets relief from those shots. An 80-plus-year-old gentleman I take care of really is not a surgical candidate, gets relief from those shots. I'll do one every 3 months for him, and I'll do it until he dies if that's what he wishes. But in terms of most individuals, there's probably other things we should be doing if the cortisone shots have to be repeated more than 3 times in a year.
There's some other injectables that we have used too. Dr. Khan or Dr. Thiessen, do you want to address those?
Yeah, there's-
Synvisc or?
Yeah, viscosupplements and they are hyaluronic acid derivatives which are injected into the joint. And in clinical trials, in some patients, they give you relief for 4 to 6 months. They don't work for everyone. I would say about 50–60% people have good results. And they may be an alternative to steroids. But the key to realize is they don't replace the cartilage that you've lost. We still don't know really how these viscosupplements reduce the pain in people with osteoarthritis, but they're worth a shot.
No
Good
pun
lie.
intended. I have a question for you about that, because there is some debate about if you use cortisone a number of times, that it actually inhibits the ability for the bone to heal itself, where if you use the Hyaluronic or the Synvisc, that would not necessarily inhibit the bone's
Yeah.
self-healing.
Yeah, clearly the Hyaluronic, they are sort of more physiologic. Now, you know, on a basic science level, clearly, I think what you say makes eminent sense. In real life, how much of a truth there is to it, we are not sure.
Okay.
But a lot of times insurance companies won't allow us to, you know, keep doing these viscosupplements, while with steroid injections, they are a bit more flexible.
So the discussion before we came out got over to supplements and chondroitin and everything. Go ahead, Chris.
I think we came to the conclusion that there are things like hyaluronic acid, glucosamine and chondroitin, turmeric with the chemical curcumin in that, and fish oil, where those chemicals are probably not dangerous to people. They've been taken in large amounts by different people, and what we find is that some people have some relief from them. It's tough for us to tell who might get relief, and so it may be worth taking it for 2 or 3 months and seeing if it helps. If it doesn't help, don't take it.
Let's move just a little bit. The question comes up, and you're down in that hot country, Lyme and
Yes.
arthritis. What do you see? What's the frequency? What's the treatment?
What I see has changed quite a bit since I started practicing in Moose Lake in 2001. We have had a lot of recognition of Lyme disease, and it is it's nice because the testing over the last 10, 12 years has been very accurate, where initially it was difficult to know if the test was going to tell you if you had Lyme disease or not. The testing now is accurate. We should be able to tell you if you've had it, and we should be able to help treat the Lyme disease very well if you have it.
Are there nutritional or requirements or guides that an arthritic person should know about? I don't know of any.
I think that specifically keep your weight in the normal range.
Well,
Yeah.
especially for the knee.
Yeah.
Yeah, all the weight-bearing joints like knee, hip, lower back, yes. And stay in shape.
And yeah, exercise, eating healthy foods, I don't think that would ever hurt anybody with arthritis, and I think that people might have more benefit from that than they would expect. Not from just the arthritis, but from all aspects of their health.
I think the other thing about nutrition, though, is that there are some people with gluten sensitivities that will develop inflammatory conditions, including joints. And so a person with true inflammation of the joint might do well to be tested for gluten sensitivity.
There is some role in clinical trials as far as nutritional supplements are concerned about omega-3 fatty acids, which are in fish oil, that they do help alleviate the severity of rheumatoid arthritis in some patients. But I would not use them sort of instead of the standard treatments. You can use them in conjunction with those treatments because rheumatoid arthritis, like I said, you know, if you don't treat it with specific medications, can cause serious joint damage and deformity and disability.
Are steroid shots, before we leave that, systemic? If you give us, are they absorbed systemically and do they affect the body?
So anything that you put onto or into part of the body is going to have some effect through the entire body, but in general, by putting it into a joint, you do cut down quite a bit on the exposure to the rest of the body. And so if somebody has one specific joint that needs that anti-inflammatory steroid effect, then an injection in there makes sense. Injections in many sites all over the body is not so much different from taking a steroid by mouth.
Gail, this person has 2 artificial knees. Is it possible for him or her to get arthritis in those knees?
In artificial knees, no.
No other comments? All right.
I mean, the prosthesis may wear out after 15, 20 years, but yes, you can't get arthritis by definition in an artificial joint.
Okay. What causes plantar fasciitis and how is it treated?
So the plantar fascia is on the bottom of the foot, from the heel
Leave your shoe on.
up to the middle. I will. I'm not going to go that far. It attaches at the front part of the heel, and sometimes it looks on an x-ray like there's a spur there. So people will also call it heel spurs. It comes from strain to that fascia, which tends to happen from standing on very hard surfaces without a lot of padding. And your body will actually help heal itself. So most of the time it's a repetitive strain, something from being used too often and too long. And healing probably works best if somebody gets more cushioning, if they hold the foot in a position like this overnight. There are actually splints that'll help do that. And there's not a whole lot of help that I've seen from things like ibuprofen or Tylenol.
And avoid going barefoot on hard floors. So when you come home from work and you kick off your shoes, put on your slippers.
Good points. Don't walk on rocks.
Don't walk on rocks with bare feet.
Or run on them. Okay, when should a joint be replaced?
Oh my.
Any one of you can weigh in.
Again, a very individual decision. Depends on what your expectations are. I mean, I have known 82-year-old ladies who wanted to play tennis and just wanted to get that joint replaced so that they can play tennis. And then I've seen ladies in the same age group who are happy if they can just go to the mailbox and pick their newspaper. So it all depends what your threshold and what your expectations are, and it's very individual.
And I think after a joint placement, people should expect that they're going to not just have that surgery and then have a perfect joint. They're going to be working quite a while with a painful joint as it heals to try and get that motion. And so there's maybe 4 to 6 months on average where people say it's just not back to where it was. And then afterwards, usually that pain and stiffness is quite a bit better.
It takes a lot of physical therapy and a lot of personal effort to get a joint back after you've done that, correct? Is there a relationship between carpal tunnel and arthritis?
Indirectly, yes.
What is carpal tunnel, by the way? We should probably, Chris, what's carpal tunnel?
Carpal tunnel, there's a natural narrow spot in the wrist here, which has a fascia, a thin, very tough layer over top of it, and you have tendons and nerves that run through there. That carpal tunnel is a narrow point and tends to, with tendinitis or swelling from thyroid disease or pregnancy, actually squeeze the nerve and cause nerve symptoms in the hand. That carpal tunnel, I don't know, I have seen people where it seems like arthritis is what narrows the carpal tunnel to cause it.
But typically rheumatoid arthritis, where you can have a lot of swelling in the wrist, and that can increase the pressure in the carpal tunnel and cause secondary carpal tunnel syndrome, so yes.
Most often, though, it's things like tendinitis from repetitive strain in there, or thyroid problems or pregnancy.
Or diabetes.
Diabetes, yep.
Gail, there's several questions that have come in regarding various portions of the back and degenerative arthritis. Specifically, let's just start. What is spinal stenosis?
Spinal stenosis is where the canal, where the spinal cord runs through the bony area that protects it. That bony area starts to encroach on it and pinches the spine, or I should say the nerves that run through the spine.
Chris, back to tendonitis. The left foot, the heel cord is sore above the heel. What would cause that, and what can they do about it? So I'm thinking Achilles.
Yeah. Overuse could cause it, a strain right away. The main thing with that is that tendon bears so much weight. It's very it's very debilitating if it breaks. And so if that tendon is hurting, that's one where you probably should get attention to try and get that healed up safely.
A quick comment on fibromyalgia. And I know that's not where we want to go, but do you want to just,
Sure.
is that an arthritis?
No, fibromyalgia is not an arthritis. Probably the best way to look at fibromyalgia is that it's a heightened pain sensitivity condition where people are more sort of sensitive to pain. And there is actually some functional MRI data from University of Michigan where they've put people with fibromyalgia and those who don't have fibromyalgia side by side in functional MRIs and looked at their brains after applying pressure at different spots. And the brains of fibromyalgia, typically they light up much more differently than people who don't have fibromyalgia. And all the treatments are basically antidepressants or central nervous system acting drugs for treating fibromyalgia. So we don't consider it arthritis.
Now, I would make one qualification there. All of the pharmacologic treatments, all of the drug treatments are, because one of the mainstays for fibromyalgia is exercise and sleeping well.
Very important, yeah. And staying active, even if it hurts a bit, aerobic activity tends to help the symptoms.
Mm-hmm.
It's a question about psoriatic arthritis. Is the psoriasis always visible? And then maybe a comment about psoriatic arthritis.
It's not. It's one of those things where
And how would you treat it? That's the rest of the question.
well, I would actually send it to a friendly rheumatologist.
Sure, yeah.
There we go.
Yeah, psoriatic arthritis, about 1 in 5 people with psoriasis can get psoriatic arthritis. So not everyone with psoriasis will get it. There is no correlation between the severity of the skin psoriasis and the severity of arthritis. So one person may have just a small patch of psoriasis and have a very severe psoriatic arthritis. Another person may be covered in psoriasis but never get arthritis. It's treated very different than osteoarthritis. It's treated more like rheumatoid arthritis with drugs that work on the immune system, and those are pretty effective. There's a famous golfer who is, you see probably his ads on the TV promoting a drug called Enbrel, Phil Mickelson, and he's...
Yes. Gail, we're back on the back again. Severe arthritis, L3, 4, 5, and there was some probably from higher up also. This person's receiving steroid shots. Any ideas? How long should they keep doing that? Should something more be done? Any general thoughts?
Well, I'm always telling people keep your original equipment for as long as you can, and if the steroid shots work, I would suggest that you continue with them, and if they don't work, then talk to your reputable neurosurgeon and ask what is the likelihood that a surgical procedure would help. And if a surgical procedure has a significant opportunity to help, then you might want to proceed. It's not that I'm opposed to surgery. It's just that I think some people see, I've got back pain, I need surgery because I've got a disc or I've got something wrong with a part of my spine. And in general, surgery just is very specific in what it helps and doesn't help everything. So surgery is not always indicated.
Question that comes up, and I've thought of it a few times myself. If a person has degenerative joint disease in their 50s and are active, what's the lifeline like? What's it going to be like as they go through the years? Is the disease going to progress? Is it going to stay stable?
Yes, typically it progresses, but it progresses at a very slow glacial rate. It's like watching paint dry compared to rheumatoid where the damage can occur very rapidly. So yes, it will progress, but progress at a very slow pace over decades rather than over months or years.
Define, one of you, define seronegative arthritis.
Okay, I think I'll take that, yeah. Well, rheumatoid arthritis, that again comes to rheumatoid arthritis. About 30% people with rheumatoid arthritis the blood tests, there are 2 blood tests for diagnosing rheumatoid arthritis. They can be negative and they can still have rheumatoid arthritis. So we call those the seronegatives.
Osteoarthritis is cutting off the circulation in a large toe. Is there anything that can be done?
That's difficult. It's tough to know how that's cutting off the circulation. I'm sorry, I can't help that.
I don't have a solution on that one either. I want to thank our panelists this evening, Dr. Gail Baldwin, Dr. Wasim Khan, and Dr. Christensen, and our medical students, Anna Gregoire, Bobby Johnson, and Austin Spronk. Please join Dr. Ruth Westra for a program next week on orthopedic problems and joint replacement, when her panelists will be Dr. Bradley Edgerton, Dr. David Fogarty, and Dr. Sam Harms. Thank you very much for watching tonight.